hold this grab. Hi Jessica, it's Dr. Buford. We're just getting started on your right shoulder. We're looking in from the back to the front. Everything that we see is magnified about 30 or 40 times on the screen. I'm going to make sure our magnification isn't zoomed in. Yeah, there we go. Now it's correct. So that's about 30 times magnification. We're looking from the back to the front. You're laying on your side. So the ball part of the ball and socket joint's at the top half of the screen, and the glenoid, which is the socket, is down below here. And as we look in here, first thing I should mention is we examined your shoulder before we started, and it was significantly loose enough that it was really obvious that you had a component of multidirectional instability, even though you're primarily dislocating in the anterior direction. And as we look into the front of the shoulder, the first thing we're going to look at is we have a gray cannula and a metal cannula. To the left of the metal cannula is your biceps tendon. We can tug down on the biceps and look up as it exits the shoulder. Pinch your alpha. And the biceps tendon looks just fine. I don't really see any significant problems or tearing with the biceps. We can tug on this side of it, and the tendon itself looks good. So that's good news. Now, the next thing we look for is the biceps anchor. And as you look down here, your biceps anchor is actually fine. And that isn't always the case in somebody who's dislocated as much as you have. But again, your ligaments are loose and your joint capsule is loose. So it doesn't surprise me that you don't have what we would otherwise call a slap lesion. This biceps anchor looks just fine. And that's pretty typical in somebody with multidirectional instability that dislocates. So the next thing we do is we're going to look towards the back of the shoulder. We rotate the camera so we're looking down. And as I slowly back up, we can see that your glenoid almost looks like an island sitting up there. We can see all the way around the posterior edge of the glenoid. We can see down here. And we can see how wide open the joint is. And that's a real tip-off that there's a lot of laxity in the joint. And so one of the main things we've got to do today for you is really close down this joint volume. And so we're going to be able to do this arthroscopically. We won't have to make that big incision we were potentially going to have to make. But I just wanted to confirm that this joint is just wide open. We can see all that extra space in there. So we've got a lot of work to do. As we look towards the rotator cuff, you're a little bit young to have a rotator cuff tear as part of your problem, but we always check to make sure. And sure enough, the undersurface of this rotator cuff here looks just fine. And so you do not have a rotator cuff tear. Sometimes older patients that dislocate get tears in the rotator cuff. So as we look down the front of the shoulder, push that gray cannula down inferior. Let me take it. Up. There we go. So as we look down the front, we can see a couple things. There's a subscapularis tendon. There's kind of a wispy middle glenohumeral ligament coming across it. That's really not very strong. And then here's the anterior labrum. We can see some tearing in the labrum. That comes from the repetitive dislocations. And then as we look down here, what should be the inferior, or the anterior band of the inferior humeral ligament right in here, that band right there, is not very well defined and is kind of medially displaced, and that's something that we're going to reconstruct. We can look through the inferior recess, and you have what we call a drive-through sign, which is kind of a soft indication, again, that you have multidirectional instability. So we're going to go ahead and get to work. The first thing we're going to do is we're going to start by placing some sutures in the back of the shoulder. So we'll go off on the video and put the camera right where that metal cannula is coming out. Pause, please. Okay, Jessica, so now we're looking towards the back of the shoulder. We've got this yellow cannula coming in the back. We're still a little bit bright. Maybe I can adjust that. Okay, and so now we're just using this rasp just to roughen up the capsule. The capsule back here is very thin, and we certainly don't want to damage the capsule. We'll roughen up the labrum as well. Our goal is to try and make these two, or this whole area sticky, like a big piece of Velcro, so it'll stick together. And we're going to go ahead and use a suture hook. It's what we call a turn to the left suture hook. So here's the hook. It's loaded with a black wire called the super shuttle. There it is coming out of the tip. And then once we pass the wire, we're going to use some non-absorbable suture to help us. And so we're going to look towards the bottom of the shoulder. There's 6 o'clock. We really want to start and have our tip come out about here. And the way that we judge our stitch is we put the tip where we want it to come out, and then we just roll our hand back. And wherever that tip hits the capsule is about where we need to go in. So we go in perpendicular, then we turn. And then once we have a reasonable bite of the capsule, we'll poke through. And now with this, I can do a shift, what we call a shift, by pulling this way. And we can see how that shifts the tissue. And then once I do that, I'm going to take this and put it through the intact labrum. Okay, and once we poke through, we'll go ahead and feed that super shuttle. We'll reach in here with our instrument that we call a pincher tool. And then once we have enough delivered, we'll go ahead and load this with a suture. This is what we call a hi-fi suture, so it's a high-strength suture, but it's soft and permanent. And then as we pull back, you can see how that brings it through. And now the trick here to really get the strongest repair is to do the same thing one more time. And so what we'll do is we'll reach in from the back, and we'll take this suture that we just passed, and we'll bring it back out of the front, and we're going to, let me get a mosquito or hemostat. We're going to pass that stitch one more time, and that's going to give us what we call a figure 8 stitch. That's the strongest stitch we can make. Now this is a 45. Okay. And so here we'll go ahead and bring in the suture hook again. We can see where our last stitch was. This time we want to come out about here, so we'll go in a little bit on the screen. We'll go in a little bit to the right, like that. And then just like before, we're going to get a bite of the capsule first. And then once we have a bite of the capsule, then we'll bring that capsule underneath the labrum. So it's a two-stage or a two-step stitch. Okay. Okay, here you go. And so now we'll go ahead and feed the other end of that suture. Does it help? Uh-huh. And as we pull it through, we'll make sure there's no twist. That looks good. And now we'll go ahead and get the partner stitch right here. And so now what we've got is what we call a figure 8 stitch. You can see why we call it a figure 8 when it looks like a crossed 8 just about. And now we'll tie a non-sliding knot arthroscopically here to secure this. Okay, so there's our post. Our post is always on the soft tissue side or on the capsule side, away from the socket. And then we use this pincher instrument one more time just to make sure there's no twist. And then we'll go ahead and tie a non-sliding knot. So you can see how once we cinch that down, it really tightens up that capsule and ligament there. You want to get out any twists in the knot. Okay. You can see how thin that capsule is, so we want to be very careful and kind of gentle with it as much as possible. So we'll tie these nice square knots. We're going to do one more half hitch, and then we'll cut the suture tails. Okay, so there's our knot. Okay, and so that's our first stitch. And again, the purpose of that stitch is to tighten the posterior band of the inferior. Go ahead and cut the suture tails there. And now we're getting ready to do the same thing with another suture anchor. But we can see how much tighter the shoulder is. In fact, it's almost pushed out our cannula. So the fact that let me see for a minute, the fact that we can't see down to the bottom of the shoulder as easily is actually a really good sign. It means that things are starting to come together here for us. So we'll hold there. We will go ahead and take our drill and our drill guide and get ready to place a second suture anchor. And we're going to want this one in. If you can get this in about here, I'll be happy. Okay. And then we always use a tap. Okay, and then finally we'll place our suture anchor. It's an absorbable suture anchor. It's purple. So you may see this little purple thing flashing by. There it is right there. Turn our flow up. Put on medium. Okay. We'll go ahead and unload that and make sure that anchor's solid. Pause, please. Okay, Jessica, so we've placed a third suture anchor in the front, and we're just showing you here as we tie that stitch down. You can see how it snugs things down. And what we've tried to do is really kind of reconstruct the anterior shoulder. Although if you think about it, if you look at a clock, we've really worked all the way from about 3 o'clock all the way around the back to about 7 o'clock. Maybe even a little bit higher, maybe even 8 o'clock. So hopefully this will do the trick. Now, there's one more thing we're going to want to do before we finish up today, and that's to close the rotator interval. It really may just act as a protective stitch just to take some of the stress off of these sutures while things heal, because there is some evidence that the rotator interval sutures don't last over time, which is why we use an absorbable stitch. But actually, well, we may revisit that. But I do want to show you that. So I'm going to go off on the video now, but we're going to come back up and show you some more in just a minute. And let me see a pincher. Okay. And then we'll, so if you can see, so I've left this gray one in, but the needle's going through this anterior-inferior portal twice. So I'm angling down to get subscap and then up to get right behind the biceps tendon right now. So now kind of at the superior edge of that incision, I'm now going to angle up, and I just want to come through, don't want to come through biceps, but just somewhere, yeah, and the closer you are to the glenoid, the more of a shift you're going to do. So I'm trying to stay down relatively low. That looks pretty good. And now we have to use a relay to shuttle it. So I'll need a grasper in a minute. Okay, so grasper. Okay, so now what we're showing you here, Jessica, is we're placing one final stitch to further tighten the shoulder. And we're going to pass a bunch of that black wire in, and in just a minute we'll take the needle out. Thank you. And so before we pull the relay, we always pull the needle out first so we don't shred the relay. And now we'll pull back. And then inside that gray cannula, we're going to load that black wire with the other end of that absorbable suture. And then once we pull the wire back, you'll see what it does here. Okay. And so now we've got that suture going across, and as we pull tight, you can see how that's going to at least protect or hopefully take some of the stress off the inferior sutures. Again, I don't think this is a permanent stitch, but I think it's worthwhile doing because of the instability that you've got. So we're going to go ahead and tie that. Just like that. It's certainly a lot more, and it's just extra articular. So it's certainly a lot tighter than it was when we started, compared to when we started. And then we'll take I need a little hemostat just to spread the skin a little bit, and then we'll use that same cutter that we used before. Okay, so hemostat. So this is really being tied just over interval tissue. Okay, good. And so now we'll have one final look around as we look down the front. Again, remember before we could just poke our camera through anywhere in the joint. Now we can't do that. Look how tight that is in the back. Remember before when we first started, it was hard for me to pull out of the joint. It was so large. We could see all the way down here. And now I can't even see below the edge of the glenoid. So we know that we've done a lot to tighten the shoulder. We just have to give it a chance to heal. So good luck to you now. I really hope this does the trick, okay? Bye-bye. Pump off.